Hello guys, we will be discussing about thyroid in this video. We will make two parts of thyroid and it will cover every aspect for all MBBS students and NEET PG and INISET aspirants. We will cover about embryology, anatomy, physiology, biochemistry, pharma, patho, ENT, PSM, surgery, OBGYN and medicine, and we will cover it in 30 minutes. So let's go. First of all, we will talk about embryology. So in embryology, it originates from foramen cecum, which is present between first and second pharyngeal arch, where anterior two-third and posterior one-third of the tongue meets, and the lining is marked by circumvallate papilla, and at the midpoint, in the third week of gestation, there forms the invagination of thyroid gland origin, which later forms the diverticula, which is known as thyroglossal duct, later pierces the hyoid bone, and later reaches the tracheal cartilage at the level of second, third, fourth. It expands and forms the thyroid gland, which later obliterates, and thyroid gland persists. Sometimes that duct remains patent and forms the cyst, which is called as thyroglossal cyst, which is subhyoid most commonly. Operation for thyroglossal cyst, we do cyst trunk operation, where we remove whole the thyroglossal tract along with hyoid bone central part. And if we ask about most common associated malignancy, it is PTC. Papillary thyroid cancer is most common associated malignancy, and it moves with tongue protrusion and swallowing, because both the time tongue will move, and as it is connected through tongue via foramen cecum, it is moving with deglutition and protrusion. Investigation of choice for its diagnosis is USG. So now we will be discussing about congenital hypothyroidism, also known as neonatal hypothyroidism. It is more common in female as compared to male. Etiology: there is a thyroid dysgenesis, which cover about 85% of the cases. Thyroid gland formation is impaired here. Then there is dyshomogenesis, which covers about 10 to 15%, where hormone formation is impaired. And then there is central cause of pituitary and hypothalamus cause. So thyroid dysgenesis, there is agenesis of the gland, non-formation. Then ectopic thyroid is not in its location, and there is hypoplasia. Thyroid is in its location, but it doesn't function well. And in dyshomogenesis, there is TPO deficiency, sodium iodide importer defect, and coupling defect. And central, as I told you, pituitary and hypothalamic. If we talk about symptoms, they will appear after 1 week, because maternal T4 will cross the placenta and will stay in blood of the children for a week, and no symptoms will appear till then. Then mental retardation, macroglossia, and umbilical hernia. These are very very high features of thyroid hypothyroidism in neonates. Hypotonia, and there is also delayed closure of fontanelles. Delayed closure of fontanelles is also a cause and symptom of congenital hypothyroidism. There is specific name given to the congenital hypothyroidism symptom known as cretinism, where neurological and musculoskeletal defects are named together. Their neurological deficit is severe intellectual disability, deaf mutism, and spasticity. In musculoskeletal, there is a short stature, which is a proportionate short stature, as it is a central cause, and delayed bone age. Now we will be talking about screening, as this is the most common preventable cause of neurological deficit. So screening in India is very rapidly done nowadays. So done within 48 to 72 hours of birth, heel prick blood sample will be used. First screening, we only do TSH, and we can also use T4, but T4 is not so good, because T4 can cross placenta, so interpretations and lab reports might be wrong. So now we will be talk about interpretation. If T4 is low and TSH is high, it means there is some defect in thyroid gland. So we will call it primary hypothyroidism. And if T4 is low and TSH is also low, will be called as secondary hypothyroidism. We will do imaging later. Here we will first do USG, ultrasound of the neck, to detect if there is thyroid present or not. If not present, then we will go for technetium 99 or iodine 123 radionucleotide scan. Iodine 123 radionucleotide scan will detect any ectopic or absent thyroid. As ectopic thyroid, I am regarding toward struma overi, we all know about it, that ovary will have some thyroid gland issue. So most common ectopic site for thyroid gland is base of tongue. Now we will talk about treatment. Levothyroxine is given and should be started within 2 weeks. Target for T4 to become normal is within 1 to 2 weeks, and TSH within 1 to 4 weeks. And again, congenital hypothyroidism is a preventable cause of mental retardation, so treatment is very necessary. Now we will proceed with anatomy of the thyroid gland, position and its extent. Upper border lie till the oblique line of the thyroid cartilage, and lower border goes till fifth to sixth tracheal ring. These are about the lobes. If we discuss about isthmus, it lie in front of second, third and fourth cartilage. There is pyramidal lobe, which is present in 30 to 50% of patients, which is a remnant of thyroglossal duct also. Anteriorly, skin, platysma and step muscles are there. And if we discuss about posteromedially, there is larynx and trachea. And posterolaterally, there is carotid sheet enclosing its contents, as in common carotid artery, internal carotid vein, and the third one is vagus nerve. Along with that, there is a deep cervical fascia which encloses the thyroid, and the deep condensation, the posterior condensation of this deep cervical fascia is lead to formation of Barry's ligament. And weight of the gland is 15 to 25 gram. This is important when we discuss about near and subtotal thyroidectomy. In subtotal, 4 gram each side is remaining, and in near total, 4 gram on one side is left after the operation. So this is all about anatomy. Now we will discuss about arterial supply, venous drainage and lymphatic drainage of thyroid gland. First of all, arterial supply, there are three arteries. External carotid artery gives a branch of superior thyroid artery. Thyrocervical trunk, which gives a branch of inferior thyroid artery, and there is thyroid ema artery, which is present only in 30% of people. One important thing to remember is external carotid artery gives a branch superior thyroid artery. Here, external laryngeal nerve lies very near to the origin of the superior thyroid artery, and same as in where the inferior thyroid artery enters the gland, there the recurrent laryngeal nerve passes very near to the inferior thyroid artery. Now about venous drainage, there is superior thyroid vein, inferior thyroid vein and middle thyroid vein. Very important point to remember about the vein is middle thyroid vein, which is ligated first in any operation of the thyroid gland. The first one to ligate is middle thyroid vein. Superior and middle thyroid vein directly drain into internal carotid vein, and inferior thyroid vein drain into brachiocephalic vein. And if we discuss about lymphatic, then mainly the thyroid gland drain into the sixth node, which is known as front of neck or Delphian node or central neck nodes. So upper pole and isthmus drain into Delphian, that is sixth node, and lower pole drain into lateral neck nodes, and these are all primary neck nodes. Later on they will drain into secondary neck nodes, that are deep cervical neck nodes, upper deep cervical and lower deep cervical. Now we will talk about injury to nerves. If we ligate superior thyroid artery near its origin, it will lead to ligation of external laryngeal nerve also, which will lead to denervation of cricothyroid muscle, and the vocal cords will not be able to tense and not able to raise the pitch of the voice. Now if we will ligate the recurrent laryngeal nerve along with inferior thyroid artery, then it will lead to all intrinsic muscles goes into spasm and glottis will close. That will lead to difficulty in extubation. As the lymphatic spread, PTC will spread via lymphatics and FTC spreads mainly via hematogenous route. Now if we will talk about physiology and biochemistry of thyroid gland produce three hormones, that is T3, T4 and calcitonin. So T3 and T4 are secreted by follicular cells and calcitonin is secreted by medullary cells. Now we will talk about thyroid hormone secretion. So brain will receive signals like cold or stress. Then there is a secretion of norepinephrine, which will stimulate the hypothalamus to release thyrotrophin releasing hormone TRH, which will stimulate the basophils of anterior pituitary to secrete TSH, thyroid stimulating hormone. We also studied in grave disease that there is a thyroid stimulating immunoglobulin IgG, which will stimulate the thyroid to release T4. Now T4 will be converted into T3 in peripheral tissue with the help of enzyme 5-deiodinase. Now this 5-deiodinase will convert T4 into T3. Now T3 will re-regulate like negative feedback to hypothalamus and pituitary in excess. Now, if we receive a signal of starvation and non-thyroidal illness or some glucocorticoid, they will inhibit the pituitary glands and also hypothalamus to stop secreting TRH, and will hypothalamus will secrete somatostatin, which will later on inhibit pituitary more. Then in peripheral tissue, starvation and non-thyroidal illness will lead to T4 converting enzyme to reverse T3, and reverse T3 will increase in starvation phase. Now, formation of thyroid hormone. Here we will be mainly focusing on enzymes. As you can see in this slide, NQO1 and GPX2, TX and RD1. All these are antioxidant enzymes which are regulated by gene NRF2, ARE and KEAP1. These are the signaling pathway which will lead to the formation of these enzymes. What is the main action of this enzyme? They prevent the oxidative stress on thyroglobulin and help in preserving the thyroglobulin, which is useful for the synthesis of thyroid hormone. Now we will be discussing about the thyroid hormone synthesis in the next slide. So before going forward, we forgot a point to mention here. Chronic estrogen increase will stimulate the pituitary thyrotropes. It is important as in PCOS condition, polycystic ovarian syndrome, there is an increased concentration of estrogen in the body, which will lead to increased thyroid secretion and heat intolerance and all those symptoms of PCOS. So transport of the thyroid hormone into the blood is done via three proteins: thyroid binding globulin, albumin, transthyretin. Transthyretin also transport retinol binding protein. And it also transport amyloid beta from brain to liver. Its misfolding will lead to amyloidosis. We know about two type of amyloidosis occurring via transthyretin, which is wild, also known as senile ATTR, which involves the heart, leading to cardiomyopathy, and there is one hereditary which involves the brain, mainly neurons. So this is about transthyretin amyloidosis. Now biochemistry of the thyroid gland. Here we will be discussing about TOBCAR. Iodine trapping. Iodine trapping is done via the sodium iodide symport present on the apical side of the follicle cell. Now iodide will be oxidized. Uh, this is inorganic iodine which will be oxidized into iodine with the help of H2O2. Here binding and organification will occur with the help of thyroglobulin, which is secreted from the lysosomes of the follicle cells. Now after binding, it will lead to the formation of MIT and DIT, which after coupling will form the T3 and T4. Now T3 and T4 will accumulate in the colloid of the thyroid gland, which later release into the bloodstream, and transport of the thyroid hormone we already discussed will happen into the blood. So peripheral conversion. Now peripheral conversion of T4 into T3 and reverse T3, as we already discussed, 5-deiodinase will convert T4 into T3, and 5-deiodinase, not 5-deiodinase will convert it into reverse RT3. Now we will be discussing about iodine trapping sodium iodide symport, SLC5A5. This gene will regulate the sodium iodide symport channel. Thiocyanate, perchlorate, phytate and tannate, they inhibit the iodine trapping, whereas TSH stimulates the iodine trapping. Thyroid peroxidase enzyme is required for iodine oxidation, and it is present toward apical membrane. Now question will be which residue? Tyrosine residue of thyroglobulin will provide the site for attachment of iodine. MIT-DIT formation, TPO will help in coupling. PTU and methimazole, they inhibit this TPO enzyme. The hormone actually store in colloid, which is extracellular material. This is the only endocrine gland where the hormone is stored extracellularly. Now hormone will be uptake by endocytosis and will be secreted by exocytosis. TTR, albumin and TBG will be helping in transport. Formula of T3 and T4 is very important. 3, 5 and 3 dash. This is T3. And 3, 3 dash and 5 dash. This is reverse T3. Reverse T3 is increase in starvation, severe illness, liver diseases. All these will lead to increase reverse T3. Now SLC5A5 sodium iodide import. BRAF V600E mutation will lead to change in NIS activity and decrease its expression in the thyroid gland. So for now this is it. We will cover rest in coming videos. Stay updated, stay tuned, and comment the name of topic you want videos on. Thank you very much.